This case involves a 41-year-old female, anonymised as Jenny, who presented to an integrated sexual health service 55 hours after a sexual assault. The situation required urgent emergency contraception, EC, and highlighted the significance of holistic trauma-informed care. Jenny's background as a married cabin crew worker, her late presentation and concerns about confidentiality underscored the need for ethical sensitivity, NMC 2018, GMC 2024. Jenny was married with 2 children, but her husband was unaware of her attendance at the clinic. Jenny was concerned he may blame her for encouraging the sexual assault. He was not the alleged perpetrator. She had a history of IBS and arthritis of the left knee. Current medication was ibuprofen PRN and Buscopan 10 mg TDS. Jenny disclosed no allergies. The case took place within a walk-in clinic, which differs from GP or hospital care and required agile, trauma-informed interventions. WHO 21 outlines the need for accessible sexual assault services globally, but UK-specific guidance such as BASH 22 and NICE 23 better frame Jenny's care environment. Introductions were made, patient ID confirmed and capacity assessed. The Calgary-Cambridge model guided the consultation, promoting a structured yet compassionate interaction, Kurtz et al. 2016. This model remains integral to UK communication teaching despite its age. Trauma-informed care principles were embedded throughout, Lausey et al. 23, ensuring emotional safety and promoting autonomy. This is particularly relevant in cases involving sexual assault, where emotional trauma is often as profound as the physical harm itself. Research shows that empowering patients with choices fosters a sense of control, which is often removed during traumatic events, Lausey 23. The model ensures a balance between clinical assessment and psychological support, which aligns with best practice guidelines for sexual assault care, BASH 22. Bangar-Hill et al. 22 demonstrated the model's effectiveness through a small-scale RCT, comparing a cohort trained in the Calgary-Cambridge model, Group A, to a control group, Group B, without such training. Results demonstrated a statistically significant improvement in the interviewing skills of Group A, though generalizability was limited by sample size and cultural context. Nonetheless, it supports the application of structured communication in high-stress consultations, suggesting that structured communication training based on the Calgary-Cambridge model can enhance consultation quality, even in complex and sensitive clinical scenarios such as Jenny's. EC is a recognised reproductive right and an essential component of women's reproductive autonomy, WHO 2021, and EC can reduce the pregnancy risk by up to 95% when taken within 5 days of unprotected sexual intercourse, known as UPSI, particularly important in the context of sexual assault. However, barriers to accessing EC still exist. Baird and Eustace 21 explore issues such as stigma, access costs, and misconceptions around EC's mechanism. Their qualitative findings, while insightful, do lack large-scale empirical data. Aitken et al. 2020 analysed a large UK telemedicine cohort showing increased EC access during COVID-19. Though context-specific, the findings remain relevant to digital expansion in sexual health services. These studies highlight the importance of fast, confidential access as required in Jenny's situation. This evidences the need for adaptable approaches to EC provision and challenges assumptions that pharmacy-based models alone suffice in ensuring reproductive autonomy. The FSRH 2023 recommends levonorgestrel, LNG, ulipristal acetate, UPA, or copper IUD for EC, depending on timing, weight, and patient preferences. Jenny's consultation occurred at 55 hours post-UPSI with BMI over 26, making UPA the most effective oral option, FSRH 2023. Whilst this algorithm reflects established clinical consensus, emerging research suggests it may be due for revision. Lee et al. 23 conducted a robust randomised control trial showing piroxicam, when co-administered with LNG, significantly reduced pregnancy risk. However, exclusion of overweight women and lack of diversity limit its immediate clinical application. These methodological choices introduce potential selection bias and raise concerns about the robustness of the findings across diverse populations. Until further research addresses these limitations, the integration of piroxicam into EC guidelines would be premature. At present, based on FSRH 23 guidance, Jenny would be eligible for either oral EC or an IUD, with the latter offering the highest efficacy and broader applicability irrespective of timing, weight, or repeated UPSI. Intrauterine contraception is often favoured by reproductive health professionals due to its long-term efficacy. Gemzor-Danielson et al. 2019 found that women choosing IUDs post-UPSI had improved long-term contraceptive adherence. It reported that 6 months post-intervention, 83% of women who chose an IUD were using effective contraception, compared to just 58.1% of those who used oral EC. Although the sample was small and the study single-centred, the findings support offering IUD when feasible. A pivotal UK-based primary study by Glacier et al. 2011 critically examines the efficacy of LNG against EC in relation to body weight and BMI. This analysis, using data from 2 randomised control trials, revealed that obese women with a BMI greater than 30 experienced a pregnancy rate of 5.8% after using LNG, compared to 1.3% in women with a BMI under 25. Notably, the pregnancy rate among obese women was comparable to that of women who did not use any EC, indicating a significant reduction in LNG's effectiveness within this demographic. The finding underscored the necessity for me to consider alternative EC methods such as UPA or the IUD for Jenny to ensure optimal efficacy. Although UPA efficacy can be reduced by enzyme inducers, Jenny's medication, Buscopan and ibuprofen, was fine. There have been no new RCTs on this subject undertaken in the UK since 2011, but the original Glacier trial remains the gold standard for efficacy data. The FSRH algorithm advises initiating regular contraception 5 days post-UPA. Jenny declined, but this recommendation is supported by robust evidence. The Bridget trial, Cameron et al. 21, a cluster randomised crossover study of 636 women, found that 58% of those offered a 3-month progesterone-only pill supply maintained effective contraception at 4 months, compared to 40% in the control group who were not. While self-reporting introduces bias, the findings strengthen support for immediate contraception post-initiation post-EC for Jenny. This study informs best practice in promoting longer-term contraceptive use. Despite the increased efficacy of an IUD, Jenny declined, and I supported her informed decision to choose oral EC, aligning with the bioethical principle of autonomy. As Lousy et al. 2023 argue, survivors of sexual assault must remain central to clinical decision-making. Following a comprehensive assessment, including menstrual history, STI risk, and drug interactions, Jenny was prescribed UPA 30 mg as indicated in the BNF 25 and consistent with evidence-based practice and national guidance produced by EMNET 2020. Kopke et al. 2014 showed that evidence-informed collaborative counselling enhances medication adherence. Though conducted outside of the UK, the methodology supports its relevance to EC prescribing. Their double-blind study, though limited by a short 6-month follow-up, found improved treatment alignment with patient values, suggesting short-term benefit in patient understanding and adherence. This is particularly relevant in scenarios such as EC, where poor understanding could lead to delayed or inappropriate use. Though 11 years old, this study was referenced due to its particular relevance to sexual assault. The study also evidences the need for continued support beyond initial consultation, a responsibility that falls to primary care in Jenny's case to ensure continuity and contraceptive planning. Even though we are a confidential service, Jenny agreed for me to contact her GP about her attendance. Jenny was counselled on EC options, screening and PEP. She opted for UPA and declined STI testing and PEP. Decisions which were respected in line by shared decision-making principles, BASH 22 and NICE 25. She was counselled on potential side effects of UPA, including GI discomfort and dizziness, to ensure her workplace safety. Her autonomy remained central throughout, reflecting RPS standards. Understanding the pharmacokinetics of UPA was essential to assess its suitability for Jenny. UPA is lipophilic and excreted in breast milk, so I confirmed Jenny was not breastfeeding. Whilst renal impairment is not expected to affect UPA elimination, its hepatic metabolism means it is contraindicated in severe liver impairment, which was excluded in Jenny's case. Brash et al. 2010 conducted a robust double-blind placebo-controlled trial demonstrating that 30 mg of UPA administered immediately before ovulation significantly delayed follicular rupture in 59% of treated cycles, with 100% effectiveness before the LH surge and markedly reduced efficacy after the LH peak. However, the study's relatively small sample size of 35 women and short follow-up short follow-up, limit its generalisability and leave unresolved questions about whether delayed ovulation consistently translates to reduced pregnancy rates. As no more recent studies of this kind were available, I felt happy that it reinforced the appropriateness of UPA for Jenny. Given her clinical profile and the reviewed evidence, I concluded that UPA was a suitable EC option for Jenny. Manufacturer data, HRA Pharma UK 23, confirms that food can delay absorption, and this was discussed during prescribing. UPA is a selective progesterone receptor modulator that works by inhibiting the LH surge, preventing ovulation, Brash et al. 2010. It acts on progesterone receptors in the ovary, hypothalamus and pituitary, disrupting the hormonal cascade essential for ovulation. Gideon Richard 21. Efficacy is highest within 24 hours but remains clinically significant up to 120 hours, FSRH 2023, making it suitable for Jenny. While there are no UK-based recent studies directly demonstrating UPA being superior to levonorgestrel in preventing ovulation in the pre-ovulatory phase, there is much high-quality pooled analysis covering pharmacodynamic trials that, although not UK-specific, provide robust evidence of UPA's superior blockade of follicular rupture when administered during the advanced follicular phase. Public Health England 2020 confirms that UPA does not disrupt implantation, countering common myths that deter usage. The distinction is important both legally and ethically in ensuring informed consent. Advising UPA alongside my mentor and within its licensing agreement provided me with an appropriate level of legal protection here. The RPS Competency Framework 21 has two domains, prescribing governance and consultation, with the patient the focus of both. The framework is linked to the prescriber's accountability and it provides a standard that it can be measured against, Ruscombe and Smith 21. Jenny was treated as a partner in her care, which is a requirement of the RPS 21 competencies and underpinned by the Code NMC 2018A, which states that practitioners must work together with patients to deliver effective care as well as empowering patients to share in decisions, NMC 2018A also. As an NMP, I must be assured that any prescribing I undertake is legal and safe, Medicines Act 1968. I understand that while EC does not constitute an abortion, the ability to distinguish between the two is essential for me as the prescriber. I was clear that EC prevents implantation, which aligns with the legislative framework distinguishing between contraception and abortion, the Abortion Act 1967. Jenny's consent to treatment was gained and it was ensured that she understood the purpose of the medication, the potential side effects and any alternative treatments available. Gaining consent is a fundamental legal and ethical requirement of all medical professionals, GMC 2024. Jenny's consultation was guided by the 4 pillars of biomedical ethics. However, virtue ethics also played a role, requiring empathy, integrity and compassion, which are particularly vital when supporting survivors of sexual violence, Broadhead 2020. Healthcare Ethics and Law 24 supports flexible application of ethical models in difficult cases like Jenny's. Her situation required open communication and shared decision-making, aligning with the principle of autonomy as promoted by NICE 23 and RPS 21. Entwistle et al. 2018 found that person-centred ethics fosters trust and emotional safety, especially in trauma survivors. Professional responsibility and accountability are essential in delivering safe, holistic and patient-centred care, as emphasised by Gold and Bain 23. In Jenny's consultation, these principles informed both clinical judgment and ethical decision-making, supporting safe prescribing. The RPS 21 stresses that professionalism must underpin all prescribing decisions, recognising that behaviours such as reflective practice, communication and bias awareness directly impact prescribing outcomes. Nurse prescribing as a cornerstone of advanced practice demands clinical reasoning and contextual sensitivity. Mitchell and Pearce 21. As Ruscombe and Smith argue 21, professional issues are inextricably linked with legal and ethical dimensions, requiring prescribers to navigate complex and often competing responsibilities. Completion of this module marks only the beginning of my prescribing journey. Continued professional development through resources outlined in this slide are essential to maintain both competence and safety. As an accountable practitioner, I am professionally and ethically obliged to engage in lifelong learning, Golden Bain 22, a requirement under the NMC Code 2018B to ensure safe evidence-based care. The RPS Framework 21 explicitly highlights CPD in Competency 9 and the NMC mandates 35 hours of CPD over 3 years for revalidation. Given that guidance in areas such as sexual health is regularly updated, for instance by the FSRH, it is my responsibility to remain current. UK-based research by Courtney et al. 2019 supports the link between CPD engagement and improved prescribing confidence, demonstrating that structured CPD programmes significantly enhance decision-making in non-medical prescribers, although the study's reliance on self-reporting without objective prescribing Quality metrics should be considered when interpreting the results. Regardless of this, the limitation, it demonstrates CPD is not only regulatory, but foundational to ensuring safe, informed and autonomous prescribing practice.